explain how much it's a highly morbidity and mortality among the developing countries. So if I take this scenario, which is very familiar to all of us, a 29 years old patient who presents to the emergency department, and this patient, she has a severe pelvic abdominal pain with mild PV bleeding since a couple of days, and she has an irregular cycles, and she cannot even recoil because of the pain her last menstrual period. She's anxious, she is nauseated. So what exactly our next step? And that will be kind of challenging because we need to get a list of differential diagnoses in a short manner. Sometimes patient present in shock, she present unconscious, and the history will be taken from her family. Sometimes the patient doesn't recall a lot of good history due to her age or due to irregularity of her menstrual cycle. So a detailed history is a really must, just to know which way that we need to divide. And I think is the challenge of everyone, whether it was in the emergency physician or a student or our resident or the sonographers. So having a systemic approach in how to deal with such a case is really essential. And why is that? Just because of most of the gynecological emergency are challenging in a way because they present with a similar presentation. In most of the presentation, when they come to the emergency department, 88% it's abdominal pain, abdominal pelvic pain, and PV bleeding. And sometimes they do have like nausea, vomiting, urinary incontinence, and other associated condition if the case is non-gynecological. So it's really important for us to differentiate, to make a differential diagnosis, because like I mentioned, they are overlapping, and we need to really tailor about what exactly we're dealing with, because to ensure the safety of the patient and early management, we need to know and to be familiar about which cases are going with what based on the history, examination, lab investigation, and also to know how to read about the radiological investigation, whether it was an ultrasound or non-ultrasound. So to be familiar with the gynecological emergency are really essential. And why is that? Because we know the progress of a chronic and the disease will be completely different. So if I'm dealing with a patient who's having a hemorrhagic ovarian cyst in the acute stage, and I'm going to scan her, so there will be a different sonographic appearance. And when this cyst will go through changes, like the hemorrhagic cyst will go under some solidification, liquefaction, and it will become a chronic mass. So the ultrasound will be completely different. So knowing the normal anatomy from the pathology and the progression of the disease is really essential. And for that, we understand the pathology changes of the disease radiological basis is really essential. So I'm going to focus mainly in the ultrasound because there's so many pathological changes can be readable by MRI, by CT. In case of the ultrasound will be limited or inconclusive. So ultrasound in emergency gynecology, it's indicated in 90% of the emergency, and approximately 23 of the acute gynecological admission in the non-pregnant woman are for suspected ovarian cyst. And that will help us a lot because 30% of those women are found to have having a cyst in their ultrasound. So having the ultrasound as a first line in the radiological investigation is really essential because, like I mentioned, because the sensitivity of the ultrasound, the availability of a very cheap instrument everywhere in the hospital, we have an ultrasound, whether it was in the emergency department or in the radiological department. And the other thing is like the admission. The result of the ultrasound will change the management. Definitely if the patient presents with abdominal pain and we think it is non-acute condition, so that will make a lot of difference to make a diagnosis and plan of management, because maybe she will not require admission. So it will reduce my admission rate by 50%. And maybe this patient will require only kind of simple analgesia, reassurance, and follow-up as an outpatient. So once again, Apart from the other radiological modalities, with all my respect, ultrasound considered an optimal modality for pelvic pathology. And why is that? Because of the sensitivity of and the specificity of the ultrasound for a pelvic pathology is really high. Now, the modality and the technology of ultrasound has become so superb that we can really correlate it with the clinical symptoms. But first of all, we need to take a proper history, then examination, then we can correlate our clinical findings with our radiological findings. So which one to choose, either transabdominal ultrasound or transvaginal ultrasound? Well, both of them are superb, but it has limitations. Of course, if I'm going to use a transabdominal ultrasound in a patient with a high BMI, or she has a lot of gas shadowing, or she is a very tender and she's not comfortable to be pressed in her abdominally. So transabdominal ultrasound will not going to be a better approach. For that, we need to evacuate the patient's bladder and ask for a transvaginal ultrasound if it's accessible and indicated. So knowing the pathology by both modalities, whether it was transabdominally or transvaginally, it's really essential, because we know that the first step, and I always emphasize my juniors, my resident, that the art of the ultrasound to have the vision on the normal anatomy and the abnormalities, but we have to start abdominally, because sometimes we cannot access vaginally because of the patient refusal, or because of not availability of transvaginal probe in the emergency department, or because of the patient is virgin and you cannot access it. So it doesn't mean that we are limited. We need to extend our approach by giving our best service by doing the transabdominal ultrasound. Definitely, by differentiating about what are the cons and the pros between the both modalities, if I'm going to do a transabdominal ultrasound, I know that we're going to use a low frequency. It has a poor resolution because the view is bigger. But the benefit of doing the transabdominal ultrasound, that as soon we can exclude a gynecological condition, we can just go upper to the abdominal part and to examine the other part, because it could be a renal colic, it could be a cholecystitis, it could be appendicitis. Well, so we need to rule out a non-gynecological condition. And so bit and piece of information needs to be accumulated so we can accelerate. And at the same time, we can filter the patient and can direct her that this is not a gynecological condition and she needs to be seen by either medical or surgical team at the emergency department. So the abdominal ultrasound, like I mentioned, it's a low frequency. It has a poor resolution because definitely it needs to go through a lot of layers, but it has a good overview. And we need to have a kind of little bit of a fluid, like the bladder should not be very distended, because that will cause a lot of discomfort for the patient. And sometimes when you're pressing on the abdominal wall, so that will give us a false elongation for certain structures like the cervix and the uterus. But like I mentioned, if it has a cons, it has a pros as well. So sometimes because of the position of the uterus, you cannot really evaluate what's going on. And when the bladder is like moderate to maximally full, it kinds of gives us kind of pitfalls like reverberation or enhancement behind the bladder. So a lot of shadowing and re-enhancement are not really good, because you not really have a good pictures. And our aim in ultrasound is to optimize our pictures, and our reflected organ needs to be different from the other organs so I can differentiate what's going on. Whether the transvaginal or transrectal ultrasound, it has a high frequency and it is having a super resolution, because the frequency is very high and the adjacent organ needs to be scanned, are very nearby. So whenever the transmitted echoes will go and hit the organ and comes back, it doesn't take long time. So the distance are small, the frequency is high, the resolution will be better, and definitely it will be focused. So it will give us a clear pictures about the uterus, the pedicles, the ovaries, the bladder, and the adjacent pelvic organ. And for that, we need to have kind of pre-examination requisition, which is the patient permission, oral consent, and the bladder needs to be empty to avoid discomfort for the patient, and at the same time minimizing as much as possible false results. Okay, the principle of the ultrasound needs to be in those follows conditions, that we need to understand when to perform a transvaginal versus transabdominal ultrasound. Sometimes most of the bigger pathology, like if I'm having a patient with a uterine fibroids and it's occupying most of the upper part of the pelvis going to the abdomen, at this particular cases, well, transabdominal ultrasound will be more preferable than transvaginal ultrasound. So knowing which one to choose, and if I get all the information transabdominally, then it will skip for me to go for transvaginal ultrasound and vice versa. The second point is to understand the importance of the orientation of the probe. So if I'm using the probe, whether transabdominally or transvaginally, how to manipulate it. And there's so many manipulation that I'm going to discuss it now that needs to be addressed very well. So we'll not like flip the pictures, and we need to do it in a systematic approach. So I need to know that if I'm going to put the probe, I need to be in a mid-sagittal view, and what's the picture that I need to approach in mid-sagittal view, how's the sweeping going to be at the mid-sagittal view, then I'm going to turn it to a transverse view, and what is my picture to be obtained, how is my sweeping going to be obtained, so I will not miss any kind of pathology. Understanding the steps of performing in a systematic manner and doing it in daily basis will make the cases, even during the emergency, very fast. So you will be even systematic in the case of the emergency, because in the emergency you just need to expedite your timing for the patient's benefit, so she will not stay for a long time. So being using a systematic approach is really essential. And my last point is to